So to carry on with the excellent ideation that was introduced by Professor Habib, I'm going to carry on with the theme of crazy ideas and how they can take shape and how they can benefit both the clinical as well as the patient community. I'm going to be talking today on largely focusing on encyclopedic tumor analysis and what's the role in refractory cancers and what's been our experience in that regard. So over the next 30 minutes or so, just sharing with you the molecular oncology landscape, how we've looked at integrating both tissue along with blood as a comprehensive molecular analysis option for patients who are struggling with the current therapy options, how the encyclopedic tumor analysis came about, what's been the data that we've shared so far with the clinical community internationally, and where are we heading in that regard. So we know that molecular characterization of a patient's tumor to guide treatment decisions is increasingly being applied in clinical care. It's had an impact on disease outcome already. We're now starting to see molecular analyses, typically which are performed on tissue at the time of diagnosis and on biopsy. However, we know that tumors are largely heterogeneous and sampling the tumor in its entirety is always a clinical challenge. Furthermore, these tumors also evolve over a period of time, as does their molecular genotype, and that allows clinical decision-making based on historical biopsy data suboptimal in my view. When we talk about precision cancer, precision oncology, it's not just looking at putting the right targets in space, looking at the right drug for the right treatment to the right patient, but it also looks at how do you provide the treatment in the right way and what's your right turnaround time, which I think is very important. And sometimes I think we overlook as clinicians in that space. One would be quite loath to look at titrating antihypertensive medication for blood pressure that was 2, 3, 4, 5 months ago. Similarly, in my view, it makes very little sense just to isolate treatment decision-making on old biopsy and old tissue without looking at real-time tumor dynamics, which are extremely dynamic and change, as I mentioned, over a period of time. So we know that cancer is a disease that's driven by mutations. Identifying them is increasingly helping clinicians to determine targets and therapy options in that regard. And those were initially thought to be or sought to be unavailable. To fully enable personalized medicine, I think it's desirable that you have an easy, accessible, minimally invasive methodology which helps determine and follow the molecular makeup of the patient's tumor on a longitudinal basis. It's impractical to keep on repeatedly doing a biopsy, which mandates a patient invariably to come into a daycare surgery or into the hospital, depending upon the anatomical subtype. And we also know that there are credible challenges of tumor heterogeneity and new mutations inducing resistance to therapy and targets to outsmart the quirks of both DNA as well as genetic targets has been evolving over a period of time. We'll discuss a little bit about the omics in terms of where we stand and how that evolved into the encyclopedic tumor analysis rationale in that perspective. So just to put the timelines into perspective of epochal turning points in terms of oncology, we know from the time of radiation in the early 1900s to looking at chemotherapy drugs in 1940s, to then looking at targeted therapies, including the TKIs in the early 1980s. And really the last turn took place in 2010 with the introduction of the immune checkpoint inhibitors for the treatment of advanced and metastatic cancers. That being said, the evolution and the change and the speed at which this has taken off in the last couple of years is in my view, quite extraordinary. It was not more than just 20 years ago when we were starting to look at rituximab as the first targeted cancer drug, bringing record survival to leukemia and lymphoma patients. And then in 1998, about 22 years ago, one of the most memorable presentations that looked at in the ASCO annual meeting in terms of the role of trastuzumab on HER2 breast cancer. And we've seen multiple papers subsequent to that, including the one in 2013, the classical paper by Denise, which actually showed that the drug had resulted till that time, over 75,000 life years had been saved since the drug had been introduced in that space. Again, we've seen a high amount of growth in terms of both molecular targets and molecular aspirants from therapy standpoints. Largely, this has been driven by immuno-oncology therapies that have focused on rapid development in the pipeline of those drugs. And we've seen a surge over the last couple of years. So this was just data that was shared by you a couple of years, I think it was last year. Again, it was showing significantly how the pipeline of targets has grown over a period of 2 years in that perspective. And again, the cell therapy class now has the largest number of active agents, second largest in terms of active trials in the immuno-oncology space. And the progress over the last couple of years just demonstrates the enthusiasm continues in the domain of immuno-oncology in that space. And we've largely seen both the United States and China leading a large number of pipeline development in that space. Moreover, despite advances in diagnostics, in medical and interventional fields, a number of new cases of cancers continue to increase, especially in the last decade between 2005 and 15 in that regard. Conversely, mortality rates haven't changed much in certain cancers in that regard, and that still remains a challenge in certain parts of the world. So cancer treatment largely has been based upon histology, location, type, and the analysis of biomarkers in that perspective. There were roughly 200 fewer treatment options available than there are today in that space. That being said, the three dynamic treatment modalities remain robust pipelines and pillars with regards to the treatment options in that perspective. And I think increasingly we're focusing now on better outcomes and to create credible data in that regard. In various parts of the world, the scenario still remains complex. In my view, it's constrained by resources. This was an excellent paper by McConnell in 2014 that was largely looking at the landscape of mutations by gene as part of the study cohort that they looked at. And you can see from the graph that the frequency of mutations indicated on the y-axis and the genes that are mutated on the x-axis and the cancer type on the z-axis in that regard. And they had almost about 3,000 mutations that were identified in this cohort. And you could actually see that the KRAS and the TP53 stood out, which are the dark green and the blue mutations that you can look at within the slide in that perspective. So even 6 years ago, there was landscaping that was actively being involved within this regard of identifying various tumor targets in that space. And we had a very, very interesting insight into the tumor microenvironment that came through looking at how that could be a partner in crime in terms of multiple stromal cell types and subtypes that would contribute to the acquisition of the cancer hallmarks in that perspective. It's become quite evident over the past decade that most, if not all, malignancies contain a heterogeneous subpopulation of cancer cells, including the stem-like properties of the cancer stem cells. And they are largely instrumental in the pathological manifestation of cancer, variably affecting the initiation, the persistence in the face of persistent barriers, the metastatic potential in that regard, as well as the ability to rebound from ostensibly efficacious cancer treatments that we've been giving. So you could look at the nice little diagram on the right, which actually shows the various hallmarks aligning to the infiltrating immune cells, the fibroblastic cells, the vascular activity of the sustaining proliferating signals from the angiogenic cells, as well as then various aspects of immune destruction, invasive and metastasis, and angiogenesis coming in from various of these parameters. Notably, the importance of each of these stromal cell classes varies with tumor type, with different organs. It's governed by various parameters of a distinctive tumor microenvironment and the underlying oncogenic alterations in cancer cells and cancer stem cells that are arising in the primary tumors and their invasive metastatic colonizations in that regard. So this is a paper in 2014 from Lee and group, and the aim of just showing that was there was already interest in terms of looking at association of multiple mutations in clinical subtypes in that regard. And this was data that they shared from over 5,000 cases of non-small cell lung cancer, which showed a panoramagram of mutations of looking at EGFR RAS, BRAF, PIK3CA in that structure. And it was really for the first time they were starting to show us both double and multiple triple mutations that were being identified in different cancer cells and how that could have an impact of multiple mutations with clinical outcomes. Again, a landmark study at ASCO 2016, close to over 15,000 patients with 50 different tumor genes that were tumor types that were evaluated across about 70 genes, looking at the circulating tumor DNA and concordance between both tissue as well as advanced on tissues and non-invasive alternatives like blood. And what this actually showed was the concordance was about 87%. However, when you brought together the samples of the tissue and the blood being collected within a period of 6 months, then the concordance was extremely, extremely high at about 98% in that regard. So we've started to see a significant evolution of biomarkers in cancer management. This is new from the time of Ashworth, circulating tumor cells, to Mendel and Matthäus looking at circulating tumor DNA in the 1940s. We're now evaluating various subsets of diagnostic markers, prognostic markers. We've seen that across various organ systems like breast cancer. There's increasing expression analysis that we're looking at for predictive or surrogate markers, and also to identify various resistance biomarkers. So it's important not just to look at individual targets, but is there any expression data from the individual tumor that helps define which drugs are more likely to work better and not. And it's not uncommon when we see variously similar molecular subtypes across similar organ systems, but the patients react very differently to the two drugs. So there's a lot more going on within the environment in that perspective. And then to link it together, obviously, with both the pharmacodynamic and the kinetic activity of not just looking at the genomic, but also the transcriptome as well as the epigenetics, and that structure, I think, carries a significant amount of importance. Major hurdles is that in every cancer, there appears to be different molecular and genomic patterns, despite the same cancer type, as I was mentioning. This, again, is challenging since we're starting to look at customized therapy, which is based upon unique genomic patterns that are evolving. And sometimes it becomes very difficult to predict the response in that perspective. So this was data from Cato a couple of years ago, which showed, again, various aspects of DNA that was being evaluated across liquid biopsy assays, and they detected cell-free DNA across about 80% of their samples. Again, it shows the different subtypes of the mutations that were found in that regard. Increasingly, when we talk about standard therapeutic implications, including FDA-recognized biomarkers, then we know that we're dealing with a very specific predictive response to FDA-approved drugs with a specific indication, which could be a level 1, like we see with the BRAF and melanomas. This could be a response to an FDA-approved drug in a specific indication, for example, looking at a meta-amplification, or looking at a CDK4 amplification in liposarcoma, or then we're looking at an FDA-approved in an off-label indication, as what we've seen with some of the RAS and the colorectal cancers in that perspective. That being said, the off-label use of cancer drugs in oncology has a long history, particularly when we're dealing with some of the rarer or the more difficult cancers in that perspective. However, access to drugs for off-label use is and does remain a challenge. Moreover, there are cases where off-label use of FDA-labeled drugs it may not be warranted if there is not enough data in that regard supporting those indications in that perspective. So a liquid biopsy is increasingly being used to look at molecular characterization, as I was mentioning, and this doesn't just relate to blood. So the liquid is not necessarily just synonymous with the blood. There's increasingly interesting data that's coming on cerebrospinal fluid when we're looking at glioblastomas, looking at various other body fluids. There's been various amounts of interest looking at prostate and urine, and looking at various different biomarkers in that perspective. And while we understand that molecular profiling increasingly is being accepted for guiding treatment decision-making, I think there is increasingly an impetus to look at a direction of moving away from a one-size-fits-all or a box therapy guideline in that perspective. There are clear benefits of looking at various liquid biopsy options, looking at advantages of circulating tumor DNA as a marker of tumor dynamics over the conventional biomarkers or imaging. One of the benefits, obviously, is that circulating tumor DNA has comparatively a shorter half-life. It allows for evaluation of tumor changes in hours rather than weeks and months. We've also seen that changes in the circulating tumor DNA, it can also predate some of the imaging studies using some of the markers by weeks to months again, and that can have significant benefits. The circulating tumor DNA is exquisitively specific for an individual's tumor because by definition, those somatic cancer mutations are being identified by the presence in the tumor DNA and their absence in the matched normal DNA. So this bypasses the issue related to confusing any false positives in that perspective. And increasingly, the rapid increase in circulating tumor DNA, along with corresponding with disease progression or corresponding declines seen with successful treatment, is increasingly being utilized within clinical practice in that perspective. However, technology remains a challenge. Within each milliliter of blood, there are about 50 quadrillion red blood cells, but you're looking at between 1 and 10 circulating tumor cells. So I think while the journey has started, there's still significantly more to look at within this perspective. The question is, what is more accurate and what is more useful in a technology to identify some of these biomarkers? And that really remains the area of focus. So tissue biopsy remains the gold standard methodology for sampling a patient's tumor for genotype analysis. There are, however, shortcomings to that methodology, sometimes issues of accessibility of different organ systems, availability, even if you've had a biopsy and there's not enough tumor content to evaluate that process. As I mentioned before, sometimes it's impractical to do repeated biopsies as a follow-up, especially when we're dealing with difficult anatomical sites, whether it's in the central nervous system or in the GI tract, looking at pancreas and other aspects in that process. And then what you see on the top right, again, is the issue of tumor heterogeneity. So intra-tumor heterogeneity means a targeted biopsy may actually miss a lesion with a poor prognostic signature, which may be the red signature that you can see in the image, whereas the rest of the tumor is of the blue subtype. When you look at various different aspects of differences between tumors, which is the inter-tumor heterogeneity, then a single prognostic biomarker may be unsuitable in some of those tumors that have evolved with a different carcinogenic pathway, and we need to be mindful of that. And then there are obviously issues of inter-cancer heterogeneity, where a feature-based prognostic marker developed in one cancer may not work for another cancer in that perspective. To leave aside the potential risks that involve with certain subtypes of biopsy, as well as methodologies of preservation, including formalin fixation, that have an impact on looking at various aspects of molecular marker changes, that also is important in that perspective. So what are the key biomarker determinants in various stages that we look at in that perspective? We know that biomarker diagnostics evolve genomic, transcriptomic, protein assays. Some of those diagnostic parameters have specific requirements with regards to the specimen, specific molecular isolation, methodology, management, material yield, anatomical and analytical normalization in that perspective. And that always remains a challenge in that perspective. And what you see from this slide is how you move through various stages of genomic analysis, from the pre-analytical to the analytical changes. A lot has been made internationally on various molecular profiling, showing different results when you're looking at different aspects of the same sample, going to different molecular analytical labs in that perspective. And I think one of the things that we need to be mindful of is really the pre-analytical stage, in terms of how the sample's been collected, how the sample's been stored, how the sample's been shipped, what's the timeline between the sample acquisition and the sample being analyzed, because some of these are dynamic changes that move within that perspective. And again, targeted treatments have been confined largely to their labeled indications and efforts at replication, therapeutic benefit, and organ agnostic settings have always been limited in that perspective. We know, however, with the recent changes with Pembro that was discussed by the previous speaker, we've also seen with regards to various pan-cancer drugs, so larotrectinib, which has been approved across cancers for solid organ malignancies, for NTRK gene fusions in that perspective. And there has been much more in terms of improvement of potential outcomes using a putative correlation between the molecular analysis and the treatment selection in an off-label or an organ agnostic setting. And that's something that needs to be evaluated, I think, within this perspective. because of a variety of various limitations that have existed, because the evidence from previous clinical trials looking at multi-drug combinations of cytotoxic and targeted agents has been limited in that regard. So this is really where the outcomes reported in previous clinical trials fell short within this perspective. And this is where we started with the concept of looking at encyclopedic tumor analysis, looking at a multi-dimensional, multi-analyte approach. There was very little data to show evidence of strategies for relapsing refractory metastatic cancers, especially looking at a comprehensive multi-analyte approach that would be synchronous of looking at various genomic targets. These could be across the DNA, across the transcriptome analysis of looking at the mRNA, looking at various tumor cells and blood cells and integrating synchronously the in vitro chemosensitivity profiling in a label agnostic manner. So this is really what gave rise to the design of the Resilience study, where labeled and organ agnostic treatment strategies for patients with relapsing refractory cancers was based upon an integrative multi-analyte encyclopedic tumor analysis approach, which captured in-depth information about multi-layered tumor interactome. And this is really where the patients received personalized drug treatment recommendations, which was based upon inputs of multiple biomarkers. And this was integrated with the in vitro chemosensitivity. So this was data that we published early in 2019, single arm, single center, non-randomized prospective trial that looked at the encyclopedic tumor analysis structure. The design of the trial acknowledged the rationale that owing to the diversity of the cancer type and the unique treatment history of individual patient, there can be no too accurate external controls for those patients. Therefore, rather than randomize the two-arm trial design, a single-arm design could more accurately evaluate and represent treatment benefits using the encyclopedic approach, and it was benchmarked against the patient's last and failed line of treatment in that perspective. Thus, prior treatment response of patients served as a virtual control arm in that perspective, and then we looked at the progression-free survival that was benchmarked against the progression-free survival of the last or the failed treatment option in those patients where the PFS was less than 90 days in that perspective. So this just shows the landscape of the genomic alterations within the intent to treat population of 126 patients that we had. Again, point mutations looking at TP53 again was one of the more common ones that we encountered in that perspective. Similarly, point mutations looking at PIK3CA or PTH1 again were frequently encountered within the perspective, and the patient-wise actionable gene alterations, which formed a large significant aspect of this perspective, showed that the access in that structure. I'm not quite sure how those red lines have evolved in the perspective. Hasn't been me, but I'm going to just carry on with the presentation. So across the 143 initial patients who received the treatment in that perspective, various combination of therapies came across in that perspective across various patient subgroups. 45 of those patients received combination cytotoxic drugs. 93 of those patients received combination of cytotoxic and target drugs, and then endocrine therapies were administered to about 21 patients in addition to the cytotoxic therapy. And what you see on the diagram is basically the waterfall chart of the best response and the waterfall chart in terms of the end response from the study perspective. And the treatment response was evaluated on the RECIST 1.1 criteria, looking at percentage change in dimension of the target lesions between the baseline and evaluation. What you can see in a majority in the waterfall is the reduction in terms of the lesion structure in that perspective. Among the 126 patients who underwent a follow-up scan and were evaluable as per the protocol, the objective response rate was about 42%. At the study completion, we had 3 patients who had complete response, 45 who had partial response, and 66 who had stable disease. And then the clinical benefit rate was determined at over 90%, which for that group was quite phenomenal in that perspective. Some of the interesting side aspects of what we evolved within the study was looking at brain metastasis. So this was a small sub-cohort that we published later. That was a group of about 15 patients who had brain metastasis at the time of intention to treat. Within that perspective, we actually found that there was no new metastasis in that perspective. And 9 out of those evaluable patients, all of them showed a partial to stable disease. And these, the primary came through breast, lung, colorectal, and an occult cancer in that perspective. So consequently, it's important to obtain durable objective response and even a disease control in a significant proportion of patient population using this aspect of the encyclopedic tumor analysis. Contrary to the discouraging or the equivocal data that's been published in previous studies, we actually demonstrated a significantly clinical impact of the encyclopedic tumor analysis. It's generally believed that the progression-free survival decreases with various subsequent lines of therapy. Thus, contemporary precision oncology trials have benchmarked PFS, largely failed across the systemic lines of treatment to determine therapeutic options. And while a 30% increase has been indicated as a significant, outcomes of the resilient data actually showed a significant achievement of 2.5 times the PFS that we found in our data groups in that perspective. Most of the study population also experienced progression of disease with a new distant metastasis. Again, this was largely within our protocol. These patients, local progression was evolved in a majority of these patients that we saw in that regard. Though objective response is a desirable aim at any treatment threshold, I think an equally important aspect is irrelevant consideration of treatment of these advanced refractory cancers is the achievement of stable disease. And that was a very encouraging sign that we saw within that regard. So just to look at certain comparisons of various data, I know a lot has been mentioned before of looking at the Shiva and some of the other studies in that perspective. And it's important to understand that while a number of these studies relied on univariate molecular marker analysis for therapy selection, there was generally restrictive inclusion criteria of those patients that were recruited. It creates, in my view, a limitation in terms of what we got in that structure. This inclusion qualification rate that was factored in was indexed in terms of comparison of some of the earlier trials in that perspective. And I think to that regard, the advantage of the ETA guided approach in the resilient is evident in the absence of any pre-qualifying molecular feature, due to which potentially all patients with solid organ malignancies stand to benefit rather than just limited to the real world patient population where tumors harbor a predefined feature in that perspective. And again, the combination of expressed genes, looking at not just the mRNA and the driver mutations, but also looking at the immunohistochemistry, provided additional amount of data with the in vitro chemosensitivity that was looked at from within the study. And that, in my view, created a significant value proposition in that regard. Though prior efforts have been made to look at various aspects of single genes as part of the standard of care in that perspective, we evaluated a comprehensive panel of FDA-approved drugs in an organ-agnostic setting, of which an optimum selection of those drugs were made. And just to state importantly, as part of the study, there were no experimental drugs that we used as part of the study. Subsequent to that, various papers have been published by the group, which has looked at various combinations of encyclopedic tumor analysis across various refractory cancers, looking at various intelligent combination therapies, looking at androgen receptor, looking at mTOR, looking at some of the aspects of response to brain cancers and brain metastasis. In some of the studies that we've looked at, for example, that's been shared in some of the meetings before, we've looked at various aspects and found a significant optimistic and a significant benefit for patients who've actually received some of the multi-therapy options using the encyclopedic tumor analysis in that regard. And again, to come back how things have evolved in that process, we've largely moved across. There's increasing acceptance across various subsets now to look at various aspects of broad molecular profiling across various organ systems, whether it's related to non-small cell cancer, whether it's related to various aspects of sequencing for breast cancer. And to move forward in that regard, what we've now started to look at are new hallmarks. So this is a study that we just published earlier this year, looking at a sizable cohort of about 16,000 subjects, and blood samples from over 5,000 patients were processed for stabilization and isolation of what we call circulating tumor ensemble or cells. So these are C-TACs, which are a cluster comprising of at least 3 EpCAM positive and CK positive cells, irrespective of the CD45 status. And what we found in this was that over 88% of the patients with local disease and over 3,000 patients which have metastatic disease, there was a high concordance with C-TACs that we found in that subset of population in that regard. So just to show you what the clusters really look at, so you can have a look at this video. What we're largely doing in this approach is looking at peripheral blood mononuclear cells that have been obtained from blood. In this particular approach, what we're doing is selectively killing the hematolymphoid cells with a proficient apoptotic mechanism. In that perspective, those are cells that are surviving are the cluster cells. So as you look at the evolution, you'll actually find at the end of the video, you start to see a large number of those clusters that are evolving within this period of time. And we've actually looked at these clusters and increasingly starting to utilize these clusters for various aspects of clinical utility. Okay. So this was just a subsequent paper that came out just a couple of weeks ago. And what we've started to do is to utilize the cytotoxic therapy agents based upon pre-evaluation. And in this particular structure, prior attempts have been made to correlate the in vitro chemo response of tumors or circulating tumor cells with clinical outcomes in this perspective. And we had 3 arms where we looked at the concordance of similar aspects of what we saw of the chemoresistance profiling across the tumors with the blood, including a blinded subset of pre-treated patients. And we saw very high concordance of looking at the resistance profiling of blood vis-a-vis the tissue in that perspective. And the third, more importantly, what in a therapy naive group, we saw innate resistance, which has a significant impact in my view in terms of how we're looking at selecting the chemo profiling, and can we use that in terms of a clinical outcome to improve some of those structures. And again, increasingly, the clusters, in my view, will take further shape. They are obviously an interest not just to our group, but to a significant number of groups that have now started to look at various aspects. And we're starting to evaluate whether in a normal population versus a high-risk population, whether there's any value to look at asymptomatic cohorts and to identify whether they carry an increased risk in this perspective. And this was just one of the studies we published in Cancer Prevention a couple of weeks ago within our group. So just to come back to the end in terms of where we stand, there's clearly a challenge that exists from a science perspective. As Professor Habib was mentioning, sometimes you do need to think out of the box. You need to look at some of the crazy ideations that evolve if you want to look at not just doing the standard in terms of where we stand, but within the importance of new technologies. There is absolutely no substitute for standardization. There's no substitute for reproducibility. You need to make sure the data is ethical, it's credible, it's reproducible across the structure. There's a need for highly standardized processes with regards to how we look at sample collection, in my view, and the speed at which the clinical information from a genomic standpoint is generated and provided back to the clinician, I think is also important. There's no point doing a molecular analysis and then waiting 3-4 weeks in a rapidly evolving cancer for that data to come in, because 3-4 weeks later, some of those molecular pathways and those structures may have changed. This was something interesting that I heard last year from Steve Yang at the ASCO Breakthrough meeting, which I think is really looking at encapsulating where we're moving to now in terms of the disruption. And clearly disruption is setting in within cancer. I think that's the only way we're going to move forward. We've seen a significant amount of that in the last couple of years, looking at new technologies, new diagnostics, new therapy agents to come through. And clearly technology combined with data, and somebody has to fund that. That study is really looking at how we will move forward in that pathway perspective. My perspective, I think it's quite clear we need to have strategies that bring together clinicians, lab scientists, informatics to, in a real time, identify, catalog, annotate what's happening on the molecular profiling structure. We are going to see, to really create a success of personalized medicine, more amount of AI data sorting to recognize patterns, helping clinicians with treatment recommendations across a largest and the greatest data subset. In that perspective, there needs to be more participation across the globe with regards to some of this research and a contribution to the technology advancements that have been taking place. I think it's important that we look at focus strategies, differentiation of practice in various models in that regard, and you do need good science to move that forward in that space. Cancer is a complex, it's a dynamic disease that can change very quickly. To fully deliver the promise of personalized medicine or personalized oncology, I think it's important that the development of reliable and robust, non-invasive and platforms for diagnosis, stratification, for monitoring treatment response are there. I don't think as clinicians we differ in whichever part of the world we're sitting in. We want better improved outcomes for our patients. We want fewer futile treatments for our patients. We want to minimize toxicity that we're giving to our patients inadvertently. And we also want to see the economic benefit of where we are. So this is the group, this is the team that gets us moving. This is where we are in the lab in India at the minute, and they've got an upcoming lab coming up in the UK in the next couple of weeks. I think just to summarize, I think where we are with the science, I don't think we know it all. I think, but it's better and we know more than what we knew yesterday. And I think that is important in that perspective. And I think it's important at times in the imperfect world that we live in, it's important to make that imperfect world less imperfect. And that I think is a positive subset. So thank you for your time. Thank you for the organizers, and thank you for the opportunity.
Thank you very much, Dr. Datta. We're slightly behind schedule. So does anyone have a question? Please raise your hand or unmute and ask the question, please. Is there no question? I'll just ask a quick question. So in terms of the technological aspects, Dr. Datta, what do you think is the limitation in order to generalize this type of approach in clinical centers? Is there a way to make this approach more feasible?
So I think it's already happening right now. I think there is increasing use of looking at various biomarkers in that perspective across whether it's looking at the tumor DNA, looking at the transcriptome, looking at the immuno-oncology aspect. I think what's important to bring it together is really more close collaboration of sharing data, looking at outcomes, and really looking at integrating those analytes and pathways. In my view, I don't think one aspect or one approach is going to help. I think it's going to be a hybrid approach. I think eventually we will need a number of multiple markers at various levels of the cancer to integrate into that perspective. And I think what we need to do is start identifying, as I call them, the dirty, the difficult cancers, and looking at those first in the perspective where we are seriously challenged on the treatment options that we can provide to our patients, similarly, just because of the limitation of data that we have, and start looking at those cancers and can you identify treatment options in those across various oncology centers across the world, and how you can start integrating those data points.
But I guess in terms of having an encyclopedic knowledge of a tumor before treatment, you would need to have a better coordination with external bioinformatics specialists that would be able to analyze the data in a way maybe the clinic cannot do it directly.
Yes, you're absolutely right. So what we do, Olivier, in our center is that everything's in-house. We don't outsource any of the structures. So we've got about 20 bioinformatics, so some excellent guys who know that data much better than I do, but they're the experts in that domain. So we actually utilize those experts in that structure and that domain. But I think where we're standing today, if there's an ability to identify the encyclopedic approach across various centers, then the way we are connected through technology today, through cloud and other mechanisms, there's a way in which that bioinformatics can be evaluated. We're starting to see various groups like GLASS and others in glioblastomas and others coming together in that regard to share data. I think the only way this is going to move forward is if you're sharing data. This is not going to happen in isolation. I think the battle's too hard a battle to win for oncology. And if we don't share data in terms of our successes and our failures of what's gone right and what hasn't gone right, I think it's important then at least we don't end up making the same mistakes that somebody's already made.
Okay, well, thank you very much, Dr. Datta.